Good afternoon. My name is Mariana Pereira. I'm a second-year resident at San Juan de Dios Hospital from Chile. Today I will present a case titled When Family History Illuminates the Path. Our patient is a 47-year-old female with history of diabetes and hypertension. She presented long-standing history of dyspepsia, pyrosis, and epigastric pain. She progressed then to with nausea and intermittent vomiting, dysphagia, and weight loss. She consulted because her symptoms worsened, developing gastric intolerance and profuse vomiting. At physical examination, she presented dehydrated mucous membranes and epigastric tenderness on palpation. Lab tests showed kidney failure, metabolic alkalosis, hypokalemia, and hypercalcemia. She was admitted to the hospital and an upper endoscopy was performed, revealing signs of severe reflux esophagitis with a significant esophageal stricture, as you can see here, preventing the passage into the stomach. This is why she was then treated with parenteral nutrition and endoscopic dilations. So, our question was probably the same that you're having right now, right? Why does this patient have hypercalcemia? After conducting a full study, high levels of parathormones arose, and this was compatible with a PDH-dependent hypercalcemia. Then, a cervical ultrasound and a parathyroid scintigraphy were performed, and this study was compatible with a primary hyperparathyroidism. Until now, we know she had this and severe reflux. And we were surprised to see that during this time, the patient presented episodes of profuse diarrhea. What were we missing then? As days went by, we delved into her family history. And we were surprised because they told us that her mother was not visiting her because she was admitted to another hospital due to a brain tumor. Also, her brothers reported history of kidney stones. This was a key clue to our case. So we kept delving, and here is the genogram of the patient. According to medical records, her mother's brain tumor was a prolactinoma. Several brothers were diagnosed with urolithiasis, and one of them underwent surgery for gastric cancer at a young age. So we ask ourselves again, how do we proceed in this challenging case? Until now, the patient's family history suggested that there could be a genetic factor playing a role in this case. And here is where the path illuminated. Maybe a multiple endocrine neoplasia type 1, MEN1, could be the answer. According to our suspicion, a cellular MRI was performed, revealing a 6mm adenoma. And evaluation of the pituitary axis revealed it and were consistent with a non-functioning adenoma. After that, a PET-CT with octreotide was performed, revealing hypermetabolic lesions at the duodenal bulb and pancreas, compatible with neuroendocrine tumors. Due to the severity of the reflux and the presence of diarrhea, we suspected that these tumors were gastrinomas, but because of the constant need for PPIs for the treatment, gastrin levels could not be taken. Thanks to the several dilations the patient underwent, the stricture was transversed, and we were able to see a lesion in the duodenal bulb, as you can see here. And a biopsy of this lesion confirmed the presence of a neuroendocrine tumor of histological grade 1. Unfortunately, gastric immunostaining is not widely available in our hospital. Now that we have put together all of the pieces of this puzzle with the clinical diagnosis of MEN1 already made, the genetic testing was performed, confirming our diagnosis. MEN1, multiple endocrine neoplasia type 1, is an autosomal dominant disorder caused by mutations in the MEN1 tumor suppressor gene, with the development of tumors in multiple endocrine organs, mainly the pituitary gland, parathormone, pancreas, and gastrointestinal tract. On the other hand, gastrinomas are gastrin-secreting neuroendocrine tumors that are more often sporadic, but in up to 25% of the cases are part of MEN1. Due to the acid secretion, gastrinomas present with Zollinger-Ellison syndrome, and these cases present with ulcers, diarrhea, reflux esophagitis, and in some cases can lead to esophageal stricture, like our patient. Surgical resection is indicated when gastrinomas are above 2 centimeters. So, now going back to our case, now that we know what our patient had, we were able to provide an appropriate treatment for her. A subtotal parathyroidectomy and many esophageal dilations were performed, allowing oral feeding. The patient was finally discharged with oral PPIs and calcium that then were shifted to tegoprazan. She received genetic counseling, and nowadays she still continues to be followed by endocrinology and gastroenterology specialists. This case highlights key clinical features that are suggestive of MEN1, and it underscores the important role of screening for gastrinomas in patients with gastroesophageal reflux disease that present with refractory symptoms or with an atypical course. Furthermore, it is a perfect example of the significant role of taking a thorough and well-taken medical history in the diagnosis process. Thank you very much for your attention.
Thank you for sticking to the time and for a very nice presentation. And now time for comments.
That was an excellent case, but I'm a bit biased, as you probably know. You really went through the case really well from start to finish, the way you illustrated the initial diagnosis, the management. Just a couple of questions and a couple of comments is there any other functioning test that you may have considered because of severe hypokalemia and the metabolic alkalosis as part of the neuroendocrine tumor syndrome in this well-differentiated tumor? Number one. And my second, my comment is that when we see multiglandular disease in the parathyroid, it's very concerning that it's MEN1 rather than the usual parathyroid adenoma. So there were a lot of clues here that this is not the garden variety sporadic disease, that there's a familial condition, MEN1. This is a classic case of MEN. So that's my comment, my question about any other biochemical test you may have ordered.
Thank you, Doctor, and it is an honor. So answer your question, another neuroendocrine tumor that we suspected could have been vipomas because of the hypokalemia. Yeah, it was considered, but because of the diarrhea and the esophageal stricture, it was not but evident that it was a Zollinger-Ellison syndrome. So that's our highest suspicion in this case.
Like vipomas are extremely, extremely rare.
Yeah.
For us, gastrinomas are
also
common,
in MEN1, it is more associated with gastrinoma. So that's why that's our highest suspicion in this case.
I was just a little concerned because hypokalemia was pretty significant, and
yes,
with vipomas, it's much more common to get this diarrhea and significant. Now, another concern is sometimes rarely medullary thyroid carcinoma, calcitonin, hypercalcitonemia can also cause a similar syndrome too, and it's a neuroendocrine tumor also. So that's something else to consider also.
Yeah, thank you for your comment.
Excellent case. I'm glad you stressed the importance of history, particularly the family history. This was the family history that really gave you the clue of this possible man. It's interesting to see these unusual cases that are presenting in the usual way. That's true. I mean, this is the way MEN presents, correct?
Yes, it is. Because as we were looking up, we were studying for MEN1, it is more typical to present with hypercalcemia at first. But in this case, she presented with esophageal stricture. So that's what delayed our diagnosis, because we were focused on treating her symptoms, parenteral nutrition, then oral PPIs, then why does she have diarrhea? So it delayed our symptoms. So maybe if you ask me what have I done before, maybe taking a thorough and well-taken medical history. So because the clue of the mother with a prolactinoma maybe suggested that there could be a MEN1 in this case.
Well, thank you. Any other questions or comments? If not, thank you very much.
Thank you.
Now we move on.